Good afternoon, everyone. My name is Lyle Wahlberg. I'm one of the partners at Telemus. We hope everyone is feeling well and taking care of themselves. At Telemus, one of the core pieces of our code of honor that we try to live by is that it's not about me, it's about you. And today, we are here to listen to one of the top infectious disease doctors in the United States, Dr. Carl Lauder. We're not going to be talking about investment ideas or markets. Today, we're trying to deliver medical facts that will hopefully allow you to sleep better at night, or at least live with facts, not fear. One of the first things when I got in the investment business was that I had to, someone told me words of advice, which were, the most important thing is our clients sleep well at night. And this is something that we believe will help you do that. There's a lot of news out there, some we can believe, some we can't. Today, Dr. Lauder will start with a little bit of update for where we are today, and then really turn it over to all of you for questions and answers. You know, at Telemus, most of our clients have become friends over the years, and it's during these times, and we've had a few of them in the past, that we as advisors and trusted advisors provide the most value to our clients. But it's really not just financial advice. We consider ourselves more than just an advisor. We're a financial life advisor, and we hope that the information that we share today with you will help you over the next few weeks. And if you ever need to talk to us, we are here as your advisor. Even if you're not one of our clients today, we are open to helping and sharing our knowledge, whether it's reviewing your portfolio or talking to you just about your asset allocation. That's what we believe is our role and responsibility as an independent trusted advisor. With that, I am going to turn it over to Dr. Carl Lauder from Beaumont Hospital. Carl, thank you so much for joining us. I'm going to let you do a little intro about the current status of the virus, and then we'll take it for questions and your answers. Thank you.
All right. Thanks, Lyle. So everybody knows that we're in the middle of a very serious situation, particularly, at least for some people, it's much more serious than others. This virus is a cousin, a mutated cousin of the common cold virus. We've had two prior cousins also in the coronavirus family. One in 2003 was called SARS and was very serious, but it was more self-limited. And there's an ongoing smoldering activity in the Middle East since about 2012 called MERS, M-E-R-S, Middle Eastern Respiratory Syndrome. And that is very serious, but luckily it's not as contagious. So that one carries around a 30-40% mortality, but it's not as contagious, but it doesn't come and go with the seasons. And now we have the COVID-19, which we've learned, and you all know, is extremely contagious. So one of the problems with COVID-19 is that every one person has the easy potential to infect, on average, 2 to 3 people. Compare this to influenza, which we're also still in the middle of this winter, which generally has the average of contaminating or infecting every 1 to 2 people that they have contact with. So it's more contagious than influenza. It also differs from influenza in that it is more lethal. So influenza has an overall estimated mortality of 0.1%. That sounds like a small number when there were 40 million people infected, you can imagine that it doesn't take much mathematics to figure out that a fair number of people are going to die, and they do every year. And they're usually patients who are elderly and have underlying health concerns. And you're going to see that that's another similarity with the COVID-19. Another big difference between the coronavirus that we're seeing and influenza is that influenza, we have a vaccine. We have actually several vaccines. And although they're not the greatest vaccine on earth, it's usually in most seasons about 50% or more protective. And it saves lives. It saves enormous numbers of lives. Because even those people who get the vaccine and get infected, it's usually milder. The other big difference between coronavirus and COVID-19 is for influenza. For influenza, we have antiviral medications. This would be similar to antibiotics for bacterial infections. And we have several of them, and they're quite effective. So the coronavirus has no vaccine at this time. People are working on it. Unlike what you're hearing in the media from some somewhat overly optimistic people, there is not going to be a vaccine for at least 6 months or maybe closer to a year. So that is not something to hang our hats on. Will there be antiviral drugs to treat it as we have for influenza? Yes, that seems like it is much more likely to be a possibility, and several drugs are being tested while we're talking here on this webinar. And they're being tested around the world. Many of them were tested in China. They're being tested in Spain, around the world, in Italy, where there's a lot of cases, and of course in the United States and Canada and the UK. So we're hoping that we'll have some antiviral drugs. The president sort of jumped the gun a little bit a few days ago and gave the impression that the hydroxychloroquine combination with azithromycin was like great and a cure. I'm hoping that maybe it will turn out to be useful. But right now, the data on that is very sparse. It's based mostly on data from China. It's based on a small case study of less than 50 patients. You know, they had 80,000 patients. And it's just not something that we should say, well, in speaking to this group, go to the bank with. It's not ready for prime time, but we're certainly testing it. And we're giving it to patients knowing full well that it may not be that helpful, but because we don't have that much else to offer. We also have 2 other drugs or combinations that we've been using. One is a repurposed AIDS drug combination called Kaletra, Kaletra, based on some data in the test tube and from China. But the New England Journal reported just 2 days ago that the results of the initial studies with this don't look too good. In fact, we've dropped it from one of our main go-to drugs at Beaumont, where I work. We're also looking at another drug called Resdenavir. And this is a drug that was shown to be active against the Ebola virus. It has activity in the test tube against COVID-19. It's an investigational drug, and it requires permission from the manufacturer, Gilead, to enroll patients in clinical trials. We are having patients enrolled in these trials also at Beaumont, as are people all over the United States. All of these drugs that are being used so far are being used only for patients who have severe respiratory distress and or are on ventilators because their lungs have failed working. These drugs, none of them are being given at the present time for patients who just have a fever and a cough. We don't have anything that's preventative. You all are aware of the CDC and other guidelines about trying to maintain our distance from each other, washing our hands frequently, and not touching things and not touching our face as much as possible. And we think that this is very helpful. And it's hoped that this will result in a slower evolution of the illness as it spreads through our community and through basically the world. The whole idea of spreading out the illness so that it doesn't all hit all at once is because we're very worried about overwhelming our abilities to take care of patients if they need ICU and ventilator care. Right now at Beaumont, we are rationing our certain type of masks, the N95 masks, and our other protective equipment. We have not run out of ventilators. If any of you read the New York Times article on Sunday, it was a very sobering and worrisome article about what happens when hospitals or countries run out of ventilators and how are decisions made as to who gets the ventilators and who doesn't. These decisions were already being made in China and are being made right now in Italy, where they're using age as one of the criteria. If we use that as a criteria in the United States, I'm a goner. I think with that introduction, I'd be happy to answer any questions.
So thank you for the intro, Dr. Lauder. So anyone, and people have already started to put questions. If you have questions, please just put them in the question box and we will try to get to as many as we can as possible. So first one, so quarantine restrictions are coming in for a few weeks at a time. I can appreciate it's a short to buy time to make better decisions, although I haven't heard this message. It seems as though this will likely go on until a vaccine is available. Could you share your professional opinion on the timeline we might be in a quarantine social distance state?
Well, you know, we're all feeling our way here because different strategies have been used in different parts of the world. And we only have one model to go by so far, and that's from China. And many of you know that we're not exactly sure if we can trust all of the statistics coming from China. If we could trust the statistics coming from China, and if we had decided to institute the draconian measures that China instituted, where basically no one was out on the street except healthcare workers and police, and they put people away, they hauled them off in nets and tents and put them away if you dared break their curfews. Well, we know that if we can believe their figures, that using those techniques, we're looking at about a 6 to 8 week period when things will calm down. They are claiming no new cases in the last 5 days. This is amazing when you consider that they were having thousands of cases a day at one time. We are using halfway measures in the United States, and some municipalities are using more draconian measures than others. New York City is on a clampdown now, and they have a large number of cases which exploded fairly quickly. We don't know what having most of us stay home from work, but other people still running around and going to shopping and so on. We don't know how that's going to affect the natural time course of this illness. I'm not sure that we're going to have to suffer with this thing until we get a vaccine. I do feel that it's very possible, as the president has stated, and he's had some advice on this in this regard, although the advice he gets differs obviously from different experts, that it may well settle down to some degree as the weather warms up. there have been absolutely less cases in some of the southern hemisphere countries. And hopefully this will bode well for what will happen here in the United States. However, we have plenty of cases in Florida and in other southern states, so we certainly can't hang on this as strictly a warm weather relief, but there are seasonal issues that go with it and natural cycles with certain viral illnesses that may give us some relief faster than we think. On the other hand, it would be unrealistic to bank on that. This is the first time we've ever seen this virus. It's a totally new virus, and we really don't know how it's going to behave. We do know that it seems to go easy on kids. Kids do get infected, but they seem to shrug it off. Unfortunately, they can still spread it to their parents and their grandparents. And if children have underlying diseases, they're also at risk. All ages can be affected, but people who are younger and healthier generally have a milder course, with some exceptions. The course will run a week or two. And people sometimes get much worse during the second week. So there's a little bit of false security when they seem to be doing okay for 5 or 7 days, and then suddenly everything falls apart. We've been watching this pattern in our hospital. So what's going to happen over the long haul? It's impossible to predict completely. It's also impossible to predict if the measures we're taking will really have too much of an impact. We know that people are getting infected no matter what we do, but we also know that when people stay home and hunker down, they don't get infected. That's for sure. And then when people do get infected at a slower pace, it allows our healthcare resources and hospitals to absorb the hit in a more leisurely fashion and not use up all of our backup resources instantaneously. So that's why it is important. And I know for this audience, everybody's wondering, when can we go back to work? When can we hire our workers back? I believe that people should be able to go back to work as long as they can maintain guidelines of washing and keeping their distance. Obviously, working from home is only applicable to certain types of work industries. I believe people will be able to go back to work, hopefully within a month.
Thanks, Carl.
Yeah,
Carl, we have so many questions, so let's
all right.
We'll go quickly through.
All right, I'll try to be
There was one that
I'll try to keep it.
there was
Yeah.
there was one that came in asking about the two different strains and about the impact on younger people versus older people. Can you just quickly tell us about what you've learned about that?
There has been some publication work on the possibility that there may be two strains, one more mean or aggressive than other. But I haven't seen this corroborated in other studies, so I'm not sure how reliable that initial data was. Young people, on occasion, for reasons that we cannot understand, who are healthy, they may not be as healthy as we know, but they appear to be healthy, can be morbidly affected by this virus, and it can be fatal. The fatality rate in young, healthy adults is probably appreciably less than 1%. The overall mortality rate in a place like America is about 2%. But the mortality rate in people who are 80, who have heart disease or lung disease or kidney disease can be as high as 15 or 20% or more.
So we've read a lot about how contagious the virus is. Can you talk about people who are still going to the grocery store, getting groceries, getting carry out food, and are people still able to get the virus from shopping bags or other things like that?
That's a great question, because that's been scaring everybody to death. we don't really know if it's really contagious from inanimate objects. We know that the virus can be detected on inanimate objects such as countertops and doorknobs and computer and phones for anywhere, depending upon the material, 1 day and several days. But it's in very low amount. When we do viral work, we talk in terms of how much viral load, how much virus is really there. The amount of virus on these substances is very low, and we don't know that detection means contagious. It sounds very sensible to follow the advice of washing down or cleaning all these surfaces before and after use. And that would include places like the door handles when you go into a marketplace or something like that. There's no evidence whatsoever that the food handlers, if you don't have direct contact with them, are a problem, and the food is definitely not a problem. If you buy food from a market, it's fine. So it's okay to go to the market. You have to keep your distance from the people in the market, and both the workers and the other people who are shopping. And clean your hands before and after the visit, and just protect yourself. It should be fine to go shopping for carryout.
So we've had a few questions come in about testing. Can you talk a little bit about the testing measures? And I mean, it seems to be ramping up over the past few days, but there doesn't seem to be enough tests almost anywhere.
Yeah, we actually have, testing has a couple of purposes. One of it is, in the beginning, the purpose was to try to determine who was sick and who was not sick. But now we pretty much know who's sick. And we are testing wildly at Beaumont. But we're also telling a lot of people who we test positive to go home because they're not sick. If people have no symptoms at all, they have no business being tested. If you have symptoms, depending upon where you go, you may be able to be tested, but you're not going to be admitted to the hospital. The decision to go even to be tested should be the same decision you would have made a year ago if you had a cold. If a year ago you had a cold, would you have gone to a doctor? If the answer is no, I would tough it out at home with some chicken soup, then that's what you do now. If you're having serious symptoms such as a high fever, a cough, and difficulty breathing, that is a reason to go to the hospital, and you will be tested. In fact, if you're having serious difficulty breathing, you'll be admitted. It should not be a panic to get tested anymore. We have enormous testing capability now. And just today, 2 more companies came online with tests that are available. In fact, one of the tests that we're putting into use very soon will have a 45-minute turnaround time to be positive. And there are tests that will be coming around very shortly that will actually be what we call point of care, where people will actually be able to test themselves. But that's coming down the pipe. So don't worry about testing unless you're sick. Forget it otherwise.
So speaking about being sick, so what type of symptoms should people look for with it? I mean, some people describe it as having seasonal allergies. How can you tell the difference? Others are talking about flu-like symptoms. How do you know to determine whether you have this virus or something else?
That's a great question. To a great degree, there's a lot of overlap with the flu. But many people, they haven't had the flu in a long time, and they don't remember what the flu is like. The flu can be quite devastating. I remember the last time that I had a documented flu was when there was the Asian flu in 1957. I was perfectly healthy 1 minute, and 1 minute later, I was in school, actually. And I was having shaking chills. I had a high fever. I became so weak I couldn't move. I was hurting all over. I had a headache. Could barely make it home. This illness, when it's full blown, is like that. People hurt all over. They have a high fever. They will have some upper respiratory symptoms. That means like a runny nose or stuffy nose, but that's actually not a big part of it. That's more like a regular cold. They may have a little sore throat. The big symptoms that are scary are the severe cough, and even that can be okay if there's any limited breathing ability. If there's any shortness of breath, that means there's pneumonia. And if there's pneumonia, you have to go to the hospital.
So going back to the testing, so if you get tested and have a negative test, is there a way to determine whether you've had the virus before?
There hasn't been, but there will be. New tests are just coming online now to measure antibodies. And I'm not sure if everybody knows what that is, but antibodies are the immune proteins that our body makes after we have recovered from an illness, an infectious illness. It's the same type of immune antibodies we make after we've been vaccinated. That's why vaccines are so good, because they give us the immunity without having to have the disease. These antibody tests have not been available yet. Some of them are just coming online right now. There was a test just announced yesterday, but I've already seen some reports that say that it may not be as sensitive. That means it may not detect all the positives. Why we need antibodies is because antibody tests will tell us how many people might have been infected and didn't even know it, have immunity, and therefore can relax. We need that data. We know the numerator on the cases. Those are the ones that are symptomatic with a positive COVID-19 PCR test. That's a test for the virus. We do not know the denominator of how many people are immune because they've already had the disease and we don't know they had it. That data will be enormously important. And once we have that data, I'm hoping the next week or two, we'll be able to do mathematical modeling and predict when this thing will calm down.
So there's been a concern about the hospital systems and just the general medical systems being overrun. Is there a concern of lack of beds or the hospitals running out of ventilators or equipment or other things like that?
Some hospitals are on the edge right now. So it's not only needing ventilators. Ventilators are a complex piece of instrumentation that requires experts who know how to run them and supervise them. A ventilator in the hands of a novice will also kill the patient. So we need ventilators, and we'll need more. Certainly in New York, I know they're running out. But we need trained people. We have lots of trained people. At Beaumont, for instance, Royal Oak, there are 8 Beaumonts in the metropolitan Detroit area. At Beaumont Royal Oak, which is an 1,100-bed facility, we have 5 ICUs with 20 beds each, not counting pediatrics or other special units. And there are 20 ventilator units in each of those. So it's over 100 ventilators. They're all being used now, but not all for COVID. We do have a large number of patients with COVID on ventilators in the Beaumont system. So in the Beaumont 8-hospital system, there are 100 patients or more on ventilators right now. And I'm sure that similar figures would pertain to the University of Michigan, St. John, Henry Ford Hospital System, the Detroit Medical Center, etc. So you can do the math. There's lots of cases there. The published figures are usually at least a couple of days behind what we're seeing, because every test that we do our own testing. When our tests come back, it takes a little while before they're validated and then reported to the publicly. As of last night at 4 o'clock, we had 2,000 tests that we're waiting for the results on. if we look at the average, the way our testing has been going, at least 25% of those are going to be positive.
So speaking about antibodies, if you get COVID-19 once, can you get it again?
Right now, we think not in the short term. The coronaviruses as a group, like many of the what we call RNA respiratory viruses, do not seem to develop permanent immunity, but that you do get temporary immunity, so that if you get it in one season, you certainly don't get it that season again. So we're hoping that COVID-19 will follow the other coronavirus pattern. So the answer is that everything we know so far says if you get it once, you're through for at least this year, and possibly forever.
So you talked a little bit about the drug combinations at the beginning. Can you talk, there's been rumors about Tylenol being okay to use, but not ibuprofen. The supply of, I'm going to butcher the name, hydroxychloroquine is unavailable almost everywhere throughout the country. Is there something that primary care physicians can prescribe to patients if they think they might have it instead of sending them to the hospital? Just a lot of different things on drugs.
Yeah, that was a lot of questions. Let me take them one at a time. So the Tylenol versus ibuprofen is evaporating. The original information was there were some signals from a couple of centers in Europe that maybe using drugs like ibuprofen or Motrin were harmful. This has been looked at more carefully now, and we're not convinced that that's the case. In fact, the World Health Organization put out a recommendation just yesterday that we probably can go back and use ibuprofen to help people with their aches and pains and fevers. So I think we're back to our standard fever treatments that we would normally use, ibuprofen or so-called NSAIDs, non-steroidal anti-inflammatory drugs, and certainly acetaminophen we feel is safe. As far as the antiviral experimental drugs, and that's what they are, they're all experimental. There's absolutely no shortage of the drugs, of the hydroxychloroquine at Beaumont at the present time, but they are not approved for use for prevention or for mild disease. And they're being given under experimental protocol. Now, there's nothing to stop a doctor who has it from providing it to a patient, but that would be very incorrect. It would be abuse, because you're subjecting the patients to the potential side effects of the drug, which they have, for no known benefit. When we give it to patients who are very sick, we're using it as part of a cocktail of a variety of things to try to save them. And we certainly don't want to use this medication for people who don't need it, given the fact that 95% of people who get COVID-19 get over it on their own.
So can you talk a little bit about your recommendation for people that have to care for the elderly, whether in nursing homes or people living on their own?
This is a huge problem. The governor of California made an interesting, impassioned plea yesterday in sort of chastising the, quote, young people, unquote, who were out at the beaches and the bars. And he said, you may feel that you're immune or safe, but your parents and your grandparents are not. And so the answer to that is we have to really quarantine or protect them from us. We don't want to go near them. And we have to basically try to protect them as much as possible. Unfortunately, there are workers who have to go to work in the nursing homes and in the extended care facilities and so on. And for instance, what we're doing at Beaumont with all of us, including myself, is I have to answer a questionnaire when I enter the hospital each time. And I have to state that I have not been in contact with a known patient with COVID-19 and that I have not had any other particular risk factors. And then I get clearance to enter the building to do work. That should be carried out basically by everybody who works in a high pressure environment where there's a potential of bringing disease into the system. Obviously, the elderly need caregivers, and it should be their immediate family. But if they're in a nursing home, it has to be the people that are in the nursing home who are really a very dedicated and committed group, and they have to take care of themselves and not take risks so that they don't take the illness into the nursing homes.
So we've heard a lot about people being high risk. So outside of the elderly population, who qualifies as high risk?
Anybody with a significant health problem. So, for instance, a young person, a good example might be, I'm not picking on anybody in particular, but someone who is overweight and has asthma, but may only be 25 years of age. That person is a high-risk person. Someone who has emphysema, someone who is just a smoker but doesn't have any obvious after effects of smoking is at significantly higher risk than are people who are not smokers. So it's not just people with bad hearts and with a prior stroke or bad kidneys, but those certainly are high risk. It includes patients with cancer who are on chemotherapy and transplant patients. They're pretty obvious when you think about it.
So you've seen a lot in the news, the comparisons of South Korea and Italy going on different paths. Why do you think Italy has been increasing the way that they have, even though they've been on lockdown for weeks?
Yeah, well, they ignored the warnings. They did not go on lockdown. They had a totally porous border for more than a month after they started to see cases coming in. They had cases coming in from other parts of Europe. They had cases coming in from China and Korea and from Iran, another hotbed. And they have not really clamped down completely until just recently. At first, they tried containment in northern Italy, where most of the cases were concentrated around Milan and that area. Now the entire country is on lockdown. But remember the old homily, the horse was out of the barn.
So can you talk a little bit more about preventative measures? People have been talking about the N95 masks. Can those be reused or washed? Is there anything else that people can do besides wash their hands?
The N95 masks should be preserved for use by caregivers of patients. They should not be used as a preventative if you're out in public going to the market. If you have a stockpile of N95 masks, for whatever reason, you should be turning them in to your local hospital because they're going to need them. The N95 masks are not originally designed for reuse. They are definitely not recommended to be washed. That seems to harm their filtering ability. They are being, however, reused because we're running out of them. So we're now, and all over the country, healthcare workers, when they come to work, are being handed an N95 mask that they use one mask for the whole day. And then that's all they have. So we are reusing them, but they shouldn't be washed. Some people are washing them. We don't know if they're still retaining their ability to prevent infection. The N95 masks also are usually what we call fit tested. As healthcare professionals, nurses, doctors, and others, every year we have to do something called fit testing with N95 masks, primarily before COVID-19 ever existed because of TB risk. And fit testing means that they actually come in different sizes, and different sizes fit different people better. And we have a technique of testing that. Right now, that's gone out the window. So that you can wear an N95 mask and still get infected, you also need eye shield, because the virus can be transmitted if someone sneezes or coughs on your face, or if you touch your eyes, it can be transmitted by eyes, not just nose and throat. So that the N95 is not the final word either. But N95 masks are really important, and they should be reserved for our healthcare workers. The regular masks do not prevent you from getting infected, but if you have a cold or if you have the coronavirus, you should wear a regular mask, because it will cut down on the amount of secretions an aerosol that you exude into the environment. So the regular masks do have a place if you're sick, but they do not have a place to protect you from getting sick.
So can you talk about the course of the virus? People say that you are contagious up to 14 days, and even read some articles that people have been carried the virus up to 37 days. How long are you contagious for, and what is the course of the virus from start to finish?
You're going to hate my answer on this, but we don't know. What we know is that one of the guidelines that seemed to hold some water was that after your symptoms are gone, if you do, and we're not doing these because we don't have enough tests, but in a research setting, and they did some of this in China, if you do the test 72 hours after your symptoms are gone, and then repeat the test 24 hours later, and if both of those are negative, it's considered that you're no longer contagious. However, we're not doing those tests because we don't have enough tests to not only do it for diagnosis, but to test people to say that they're no longer contagious. There's one other big mess that we're learning about. The virus is found in our feces, in our stool. And it can be found in our feces and stool for weeks after we recover, for several weeks. That means that there's the potential for contaminating our sewage supply system, which is really our water systems. I'm hoping that our sewage disposal techniques that kill things in the sewage will be able to kill the COVID-19, and I believe it will. But that means that bathrooms and toilet bowls are a source of potential spread.
So everyone loves their pets, and many people would do anything for them, but are their pets, can they get the virus or spread it?
The word on this is, and it's been very solid, is your pets are safe. And they're safe for you.
Okay. So can you explain the difference between an airborne virus like the measles and the COVID-19 virus? Is it possible that the COVID-19 virus is airborne?
No, it appears to be what we call droplet. And droplet means you've got that 3 to 6 foot distance, and that the droplets usually settle pretty quickly to the ground. Airborne is the worst, because if you have airborne, it gets into the ventilation system, and one person can basically contaminate a whole building. This is not airborne.
So once this problem is under control, does it ever really go away, or will someone always have COVID-19, the opportunity to transmit further?
We don't know.
So
SARS,
talk. Oh, go
the one that was the SARS, the original prototype before this cousin, did go away. So I'm hoping that that is useful. But MERS, the one in the Middle East, has not gone away. So we have two conflicting models.
So I know people have talked about getting pneumonia vaccines. Does that help at all with the cough?
No, I've had many calls about this. Of course, we recommend the pneumococcal vaccine for people who meet the criteria that they should be getting it. As most of you may be aware, all of our children are advised to get a special type of pneumococcal vaccine that's designed for children called Prevnar 13. And they get 3 doses in the first year of life. And then they get additional doses before they go to school. Adults do not need the pneumococcal vaccine until they turn 65, unless they have certain illnesses under age 65. And guess what? They're the same illnesses that are the risk illnesses: asthma, smoking, heart disease, lung disease, etc. They will help you to prevent getting severe pneumonia due to the pneumonia bacteria. They have nothing whatsoever to do with COVID-19.
So how can someone care for somebody at home if someone's spouse or child has this?
If there's a sick person in the household, there's a very good chance that others in the household will become infected. Some of them may have no symptoms, some of them may have mild symptoms, and some of them might get quite sick depending upon their individual risk factors. Once a family unit is involved, there's not much we can do to stop it from spreading in the household. It's hard unless it happens in such a fashion, like a kid coming home from school, or let's say from a semester abroad in Italy. If your house is set up in such a way that you have a separate bedroom with separate bathroom facilities and can feed them separately and not contact them directly, it's entirely possible that the other household members can avoid being infected. But in general, it would be very difficult to avoid being infected. Just look at the example of Tom Hanks and his wife, Rita Wilson. They were both infected, one right after the other. And we've heard about other people in the media. And I'm sure we're just going to hear very soon about some of our politicians who have been infected. We'll hear probably pretty soon about some of their office workers and some of their household people also getting infected.
So if COVID is a droplet transmission, why is it more contagious than other droplet type viruses?
You know, there are different characteristics of infectious agents, and we can only describe the pattern. We don't necessarily understand exactly why one is different than another. We can't really explain it at this time. It just is what it is.
So there's been so much news out there and data from different sources. Where's the best place that people can turn to for good data? And are there anything positive coming out from any reports in the US or anywhere else?
Right now, I'll take the last one first. Right now, we're mostly, it appears, on the upward slope. We're still accruing cases in certain areas, particularly the high density population areas such as New York and LA. Looks like Metro Detroit is getting into the act. There are parts of the country that are more rural. We don't know if the reason they have less cases is because they have less testing or if they really have less testing, less cases. If you're a farmer and you're mostly on the farm, you have contact with a lot less people. So a lot of the middle of America seems to have less cases than the coasts. The only good news so far is that places that have a lot of cases are instituting measures that will hopefully take hold. We do not have a situation yet that we hear is happening in China or Korea where we've turned a corner. We do not have that yet here.
Carl, I really wanted to thank you for taking the time today. One more question for you that I know you and I have talked about. So much of what we do, for our clients, and we're fortunate that our clients do have the ability sometimes to make charitable donations. Is there anything people can do from a charitable standpoint that could help you in the medical field, or can add to the solution or solving this problem?
Yes, there's actually a lot that people can do, and I realize, and I'm speaking to a group of people who are in the business world, and we all know the impact that this is happening on the business climate. The CEO of Beaumont, John Fox, some of you may have seen his message on LinkedIn and other places, talking about what's happening at places like Beaumont and other healthcare facilities where we survive because of basically the low-hanging fruit, which is clean elective surgery and healthy people visits. And we have none of that right now. All surgeries canceled. Everything we're doing now is high cost, and every healthcare facility in the country is going to go broke. And if Delta is going to need help, perhaps, and if other industries are going to need help, the healthcare industry is in big trouble. The American Hospital Association estimated $100 billion. Mr. Fox estimated that it may take as much as $1 trillion to save the healthcare system in this country if this goes on for more than a couple of more months. So certainly anybody who's in the position of making a donation to your local hospital for such things as general care, salaries of nurses, salaries of laboratory workers, and things like this. Also, there's research going on, and we have research going on at Beaumont. There's research going on in all of the major healthcare centers. We have a study that we're just trying to get off the ground right now with a new agent to treat patients with COVID-19. It's a repurposed medication that's on the market now for other reasons. And we have a study that is going to our Human Investigation Committee tomorrow morning. We'll be treating mildly ill patients in a double-blind fashion. That means neither the doctor or the patient will know whether they get the drug or they don't get the drug. But we'll be treating all patients who are in respiratory distress on a ventilator. Will have the option to get this drug if they want it. We've applied for federal funding. This has been speeded up because of the COVID-19, but there's no chance that money would come through in less than a few weeks. So we're asking for people, if they want to donate to Beaumont, to this particular research project. I'm one of the people that's actually participating in this project. The lead scientist on the project is Matthew Sims. He's our research director in the Division of Infectious Disease at Beaumont Hospital. and a MD and PhD and a proven research scientist in the field of virus diseases. Matt has come up with this idea that we have a team of people. I work on it because I'm also involved in immunology. This is an immunomodulating drug, the hope of which will help the body defense fight off the infection better. And if people want to do something for this, right now you can't do anything because there's no number to give you or a place to send the money, but there will be, hopefully, by the end of the week.
Thanks, Carl. And just so everyone knows, we are going to summarize as many of the questions as we can and try to get Dr. Lauder to answer them. And we will send out or post the answers to any questions that were not answered today. And if you are interested in donating to Carl's research effort, reach out to your Telemus advisor or to telemus.com, and we will put you in touch with the right person there. Again, please, everyone, take care of yourself. Hope your health and your families are good in these times of distress and fear. We are here to help you with your financial life. We hope you enjoyed this webinar this afternoon, and hopefully it gave you some clarity on facts that you did not hear somewhere else. So, Dr. Lauder, again, thank you so much. And everyone, please take care of yourself, and we'll talk to you soon.
Thank you very much.